Hello and a very good afternoon, everyone. First of all, I'm very glad and grateful for all of you to sparing your time from this busy Monday afternoon. But I assure you, this is going to be worth your time. Beginning now, this is your host, Dr. Aditi Nanda, warmly welcoming you to today's webinar. It's a pleasure to welcome amongst us an enthusiast, an achiever, a hard worker, an ideal for all of us to look up to. Specializing in the branch of oral medicine and radiology and having practiced clinicals for more than a decade, the lady decided not to stop there. She did fellowships in implantology, trained herself with advanced imaging Cbct, and to our surprise, even 3D printing. And as of today, she's pursuing her PhD. Yes, PhD in oral medicine and radiology. Clearly, for her, sky isn't the limit. I'm sure you must have heard her before, for she has been the guest speaker to numerous national and international conferences. And lucky enough, we are again privileged to be enlightened upon by her. Ladies and gentlemen, she's none other than the very gifted Dr. M. Devanayagam. Ma'am, what a pleasure it is to have you with us. I, on the behalf of the whole team at Dentist Channel, wholeheartedly welcome you amongst us. And I thank you for being with us today.
Thank you, Dr. Aditi. Thank you so much for the best introduction ever I had. And today we are going to discuss about this advanced imaging technology. And I am really thankful for the Dentist Channel for giving this wonderful opportunity again and again. And thank you so much for trusting me. Yes.
The pleasure is ours.
Thank you. Thank you.
So just for our participants to know that they can put in any queries that they might have in the Q&A box given below, and they'll be addressed in the end by the master herself. So, ma'am, we can begin with the screen share and the webinar. Thank you so much.
Thank you. So students also can join now, Dr. Aditi. Can you hear me? I'm not able to hear.
Hello?
Hello? Yes.
Yes, ma'am. The link is open for the students to join and they'll gradually join in.
Okay. Yes, they're joining now. 1 second. Yes. Thank you so much for waiting. Shall we start? Yes.
Yes, ma'am. You can begin. Thank you.
Yeah, good evening, everyone are present here in this webinar, and today we are going to discuss the topic about diagnostic applications of cone beam computed tomography in general dentistry. So generally this cone beam computed tomography still people in the beginning stage, they are considering as an advanced diagnostic technology, but in many of the states, many of the cities, they have started already using for this implant planning and other advanced surgeries for the zygomatic implant, pterygoid implant, all those techniques, they are simply using this Cbct. But before prescribing this kind of advanced imaging modality, we should be knowing whether this is really needed for that particular patient, or we can generally refer for every cases, like how we are referring orthopantomograph OPG for all the cases. Likewise, we should know when we are changing into this, when we are shifting from 2D to 3D. So that is the main point, you should be knowing that. Before that, this we all know we are gradually changed from the conventional to the digital technology. Initially, we are having the dental film combination. Nowadays, we are comfortably using digital technology like PSP plates or RBG system. Likewise, the evolution is happening everywhere. In radiology also, we are changing from conventional to digital, and now we are moving from the 2D to 3D. We will discuss about whether it is good or bad, whether when we can refer, or myth and facts about CBCT, or whether it's hype to one or not. We will discuss one by one today. So these are the questions mainly all general dental practitioners, they will be having in their mind. So what is actually CBCT? Why they are hyping about the CBCT? Because we are having already CT in our hand. If 2D, IOPA, OPG, lateral ceph, all those conventional technologies also available, and CT is also available, then why we have to opt CBCT, right? And how to identify the eligible candidate for that particular CBCT, for based upon the field of view, how you can select what it shows, and how can I read if they are giving the CBCT image to me? How can I open the image and how can I read those images, interpreting the CBCT? Whether it is affordable for the patient or not. When we are doing multiple treatment, like if it goes beyond the 5-digit, whether patient can be affordable for this kind of 5,000 bucks CBCT or not. So these are the questions will be there in general dental practitioners. So we will see one by one. So as I told you, evolution is happening everywhere. Starts from the kitchen, we are evoluted from the basic to advanced technology, right? So likewise, how this 3D technology is also evoluted from 2D conventional imaging because of the limitations of 2D. It's nothing like we haven't developed anything without the reason. We have done all those based upon the research, based upon the meta-analysis, all those things we have evoluted from the 2D to 3D. So we can learn different dental imaging modalities, the scenarios as to when CBCT might be an imaging mode of choice, and what about the radiation dosage to the patient, and how to systematically review the CBCT scan. These are the things you can learn today webinar session. So generally, this CBCT can be called as cone beam volumetric tomographic imaging also, because tomography means it's a slicing. Tomo means slice. So we can see every anatomical landmark slice by slice. So that is the definition of your cone beam volumetric tomography. So as a volume, you are seeing slice by slice with the help of cone beam radiation dosage. In contrast to CT, we are having fan-shaped image, fan-shaped radiation point of entry, but here we are having cone beam entry. So when we are exposing this kind of ionizing radiation, like IOPA or OPG, any other 2D imaging radiology, the CBCT also is passes through the different densities. So here also you can see the same radiolucent landmarks or radio opaque landmarks. All those airways, sinuses, all the air kind of things absorbs very little amount of X-rays. It appears as black in color. But here, the enamel, dentin, other bone kind of stuff will appear as a radio opaque. How like in 2D, like in 2-dimensional imaging also the same thing. So here, radiation dose is the main thing we always concern about when we move on to the CT or CBCT. So in CBCT machine, this radiation dose is mainly based upon the machine parameters, whether we are choosing a small field of view or large field of view. Field of view means it's a radiated area where we are sending the radiation, whether it is smaller area like one tooth you are going to focus, or the entire skull itself you are going to radiate the patient. So that is the field of view. So depends upon the field of view, obviously you can control the radiation dosage to the patient. And even KVP also, you can reduce the KVP up to 60 KVP, or you can increase the KVP 80 or 82 KVP based upon the patient's gait or patient bulk, nature of that patient. So milliampere also we can control. Whether we can choose continuous beam or intermittent beam, that is also decided by the machine parameter, and number of images, the basis images. So this is the main factor you should be considering, like when we are going to send a CT and when we are going to do the CBCT. So CBCT is always one step ahead of CT in our dental field. So only two things are a little bit superior than CT. Other points, everything are superior to the CT. Two things only inferior to the CT. What are the two things means? Soft tissue contrast. So CBCT will give you less soft tissue contrast and it gives more scattered radiation also. That is the two major points you should be note down between the CT and CBCT. So why we are having this kind of thing means CT is general conventional tomography is always having a bone window and soft tissue window is also there. But in CBCT, we are having less soft tissue window. That is why soft tissue contrast is also very less. But we are having so good quality bone window. So in cone beam computer tomography, you can see bone pathology, bone abnormalities, tumors, everything very well in bone window. But soft tissue resolution is very less. So these are the comparison between CT and CBCT. CT uses fan-shaped beam and CBCT uses the cone-shaped beam. And here detector size is very linear and thin. That is why noise is very less or scattered radiation is very less in CT. But in CBCT, it's a flat panel detector. So whenever the X-ray source is coming from the CBCT, that X-ray thing, it reaches the large single flat panel detector. So scattered radiation is very much higher. So because of the scattered radiation, noise is also higher. But in CT, we are having single thin linear detector. So entire X-ray source will be hitting on that particular single linear detector. So scattered radiation is also very less and noise is also very less. Here we are having 360-degree rotation. Here also CBCT also will give one sweep motion of 360-degree rotation. That is the advantage of CBCT. Here we are having high dose in CT. We are having here and CBCT is at 20 to 150 microsievert radiation dose. It's obviously higher than OPG, but still, when you don't need to recommend CT for those kind of cases. Whenever you feel, okay, the 2D imaging or OPG is not sufficient to detect abnormalities, I need to refer this case to CT means, then you can opt for the CBCT. If you are comfortable with the 2D imaging, then it's well and good. You don't need to refer for the thing. But when you want to assess one structure in three-dimensionally, you are not able to see the minor abnormalities, then you can refer to the CBCT. So it has CT has both soft tissue and hard tissue window. In CBCT, as I told you, the soft tissue resolution is little bit. So CT is a larger size machine, but CBCT we can have it in-house also because it's a smaller size. CT we generally have it in hospital-based setup. This here is a vocal resolution and isotropic, but here all the X, Y, Z size of the voxel cube is always isotropic. That is why the contrast is good. Bone contrast, everything is good in CBCT. So vocal size depends upon the slice thickness. Here it depends upon the pixel size. So if pixel is smaller means the resolution will be very good. If pixel is going higher, that mid FOV, large FOV, full field of view means pixel size will be increased. Once the pixel size increases means the resolution will be reduced. So it's always inversely proportional. Pixel size is inversely proportional to the resolution. So if you are going for the small pixel, very good clarity image you can get with the CBCT. So CT is always higher cost, but CBCT you can take it from the 500 rupees itself. The basic smaller FOB you can take with the 500 bucks. You can assess all those endo analysis, everything with the smaller FOB itself. So that is a major advantage with CBCT. Now let's go to the little bit principle side, because we know before prescribing CBCT, you should be knowing what is there inside the machine. So image production, visualization and interpretation, these three components major thing in cone beam computer tomography. So here we are having some rotating gantry or C-arm which has this X-ray source and the detector. One side is X-ray source, another side is detector. So the X-ray source is passing through the patient and taking up the information and reaching the detector. We are having different types of detector. Generally, flat panel detector is used in CBCT. So an activation, once this image information crosses the patients and reaches the detector, then this kind of images, that is called basis images. We can call it as raw image or base image. So base image means the n number of images, slice by slice, it takes up from the patient and it reaches the system. So here we are doing some multiple back filtered projection algorithms. Some mathematical calculation will be happening within the software, and it gives us a reconstructed image. So initially basis image will be happening. It's like slices of stackable slice of lateral cephalometric image is called as this basis image. Once we get the stack of images, we apply all this filtered back projection algorithm, and we can reconstruct the image in multiple MPR view, multiple planar reformation. So it gives 360-degree window, 360-degree views. We can, during the rotation, multiple sequential planar projection images are happening. That is called basis, frame, or raw images. Okay. So then this several hundred basis image with the complete series known as projection data. So cone beam geometry captures entire volumetric data within 5 to 30 seconds. The first generation CT machines that takes minimum of 30 minutes to take the entire process. Nowadays, we are having 5 to 30 seconds. Imagine how we have revoluted from the first generation CT, because initially the processing time takes 2.5 hours. So 30 minutes of X-ray radiation to the patient and 2.5 hours of processing time. So you will get the image after waiting of 3 hours. 3 hours only we will be receiving the CT data. But nowadays we are having 5th generation CT, Cbct machines. We have just 5 seconds, 5 to 14 seconds. Actually, we are having our dense place Aurora machine in our college. It hardly takes 14 seconds, and we can do the processing in 2 to 3 minutes. So in that advanced technology we are having nowadays. So next thing is field of view. Field of view matters a lot in while prescribing our cone beam computed tomography. Here we are having this kind of field of view as a cylindrical shape. So based upon the height and diameter, you can opt the field of view. So if you want to go for 1 teeth or 1 to 3 teeth, you can opt for the 5 by 5 size. 5 inch of height and 5 inch of diameter. That is more than enough to assess the particular 1 or 3 teeth for the endodontic purposes. Or else you can go for the mid FOB 8 by 6 or a large FOB 12 by 8, or else full FOB that includes the entire skull. You can assess the airways also. So that is called large or full FOB. So we are having different types of FOB. It depends upon the manufacturer, you can choose. You can buy your own machine also with smaller FOB itself. So that is the beauty of this Cbct machine. So you can see the image where it covers in the skull. Small, mid, large, and full FOB. So as I told you, this pixel size gives you a better resolution. This, you go for the smaller pixel size, 0.2 mm means this will give you a nice resolution. This will be useful for your assessing the extra canals or accessory canals, lingual canals. All those will be helpful with the smaller FOB, 0.2 mm pixel size. If you opt for the 12-inch FOB, then the pixel size will vary. It goes up to 0.4 mm. Resolution will be little bit less. It will be useful for the surgical purposes. But for this endodontic thing, you can opt for the 0.2 mm pixel size. So as a charge coupled device with the fiber optic image intensifying screens also available, and this flat panel detector Cbct is also available in the market. So voxel size, as I told you, CT machine, we are having anisotropic voxel, but in cone beam computed tomography, we are having isotropic voxel size, which gives you a complete perfect contrast. So this fan beam geometry produces less noise in CT machine. In our flat panel detector and Cbct machine, little bit noise is on the higher side. 80% of noise is there in Cbct, but we have the software options in Cbct navigation tool. You can definitely reduce the noise and increase the resolution. Okay. And reconstruction process, once we receive the data, raw images data, we can do this reconstruction process in our entire console system. That's called acquisition stage or reconstruction stage. So once we receive the data collection from the machine, offset correction, linear gain calibration is happening, then interpolation correction, finally artifact correction is also happening. All this happens with the filtered back projection algorithm. It's completely mathematical algorithm that do this kind of reconstruction process. The image, coming to the image display, once we have done this entire algorithm processes, it appears in a multi-planar reformation stages. We are having 3 different type of slices, like axial slices, sagittal slices, and coronal slices. This is called multi-planar images. So tomos, the cutting into slices, we can see in the different slices based upon the long axis of the particular anatomical landmark. We can see slice by slice in 3-dimensional view. This is the commercially available software. There is n number of software available to see, like Kodak CADstream software, or One Volume, On Demand, Sirona, Sedaxis software, Galileo software, Blue Sky Bio, the free software. So you can use any software to interpret or read the scans once you acquire from the image center. So many applications. Now we move on to the general dentistry application. The first thing is soft tissue viewing. Even though it has a lesser bit of contrast resolution, lower on the soft tissue side, but still you can use it for the patient awareness thing. Okay, whether your face is for orthodontic purposes, or face correction, or smile correction, or whether you are going for the surgical correction, or you can treat with the Botox itself. So in that kind of treatment planning, you can decide with a soft tissue window. So this is, for example, of CS3D imaging software. And this is one of the Sedaxis software, comes along with the Dentsply machine. So you can see here, axial window, such a coronal window, cross-sectional window. This is axial window, 3-dimensional. And the first thing is reconstructed panoramic window. So generally, we transfer this image in DICOM format. So digital imaging and communication in medicine standard. So DICOM format is the mandatory format to read the CBCT. It won't be readable from any other format. So DCM is the only format we can read CBCT scan. These are the commercially available softwares. Yes, this is the reconstructed panoramic view. This is the implant view. I'll tell you applications one by one. So before that, you can calculate this kind of radiation dose before prescribing the patient. So the secret behind reading the CBCT scan once, if you want to do for the general dentistry purpose, other than implant planning, you can use it for the multiple dental field. That is what the main purpose here, because many people will be thinking like, okay, it's useful for the surgical guide fabrication, surgical template fabrication, or else it's useful for the only implant, pre-implant, or post-implant bone defect. It's also there, but many other general dentistry application is also available. We will be discussing one by one. But once you learn to read the CBCT, then it will be easy. Okay, you can refer the patient for all the cases. The secret behind that is know the normal. So now, if you know the normal anatomical landmarks, then you can easily point out that abnormal pathology inside the scan. So we all know this skull landmarks from the various curriculum itself. But still, if you should be knowing this landmarks from the bone to the scan. How it appears as a scan is totally different how we are seeing in the open skull. So axial section is generally, it's useful because axial section, it's a bird view. If you want to see the skull from the top view, then it's called the axial slices. So axial slices, it will be useful to assess lateral and medial wall of the sinuses, lateral walls of the nasal cavity, fracture, skull base, medial and lateral folds of the condyle. So all the side structures from the lateral to the medial structure, you can be assessed through the axial slices. See, this is at the level of inferior orbital canal or lower part of the orbit. If you are seeing from the top, from the bird's view, you can assess all those anatomical landmarks. So if you know the normal anatomical landmark bilaterally, obviously you can see the abnormal thing. So bilaterally how the sinus appears, how bilaterally the medial pole or lateral pole of the condyles, bilateral visualization of the mastoid air cells, zygomatic arch. If you know zygomatic arch bilaterally, then you can easily point out the fracture point where it fractured. So that is how you can assess. See, whenever you are seeing basilar part of sphenoid bone here, no? Whenever you are seeing the sphenoid bone, you can easily assess the condyle also here, condylar process. So this is the major landmark. So once you read this CBCT scans, you can easily read CT scans also. So this is the basilar part of sphenoid bone. Simultaneously, it shows this condylar process. And here you can see foramen ovale, foramen spinosum. All the foramens appears as a radiolucent, and sinuses also. Here nasolacrimal duct. This is like carotid canal. So all those landmarks you can easily assess with the axial slices. Here also the maxillary process and maxillary teeth, oropharynx. See, if you go one by one, slice by slice, at the top of this maxillary teeth, you can start seeing this oropharynx. So you are seeing from the top to the bottom. So at the level of maxillary, you can able to see oropharynx easily. Nasopharynx, oropharynx. You can assess the airway space. Next, we move on to the coronal view. Coronal view means front to back. So you can see front view first. At the slice by slice, you can go from the front to the back area. Here you can see the superior surface of the condyle glenoid fossa complex and symphysis region. So all those extension of the paranasal sinuses you can assess with this coronal view. So you can see from front to back. Front means you can obviously see this orbit area, the entire radiolucence area you can assess. First slice orbit, then superior nasal concha, middle nasal concha, this nasolacrimal ducts, bilateral maxillary sinus. See, you can easily assess this bilaterally maxillary sinus. If you are able to see some radio opaque area or mild tissue thickening, means obviously patient is having mucositis. In that case, for the implant planning and all, you should be very careful before placing this, because the patient might be developed with the mucosal inflammation here, bilaterally, this area. So you can easily assess with this coronal slices. See here, as I told you, even in the axial slices, this sphenoid bone, whenever you are able to see sphenoid bone, means immediately the condylar process appears. So this is like you can assess condylar process or osteophytes, any bone abnormalities in the temporomandibular joint area. How about the joint space? So you can reformat the image and see the condyle morphology. Sagittal view. Sagittal view means from the side to side. If you cut the image from right to left or left to right, slice by slice, you can see the sagittal area. So it gives you a nasal concha, condyle glenoid fossa relation, paranasal sinuses, a course of the inferior alveolar nerve. Whenever you want to see inferior alveolar nerve mapping, or if you want to see the course of nerve area, where it originates, where it exits, how it goes. If you want to see the bifid mandibular canal, sagittal view is the best view to assess this inferior alveolar nerve. So here you can see the side by side zygomatic bone, condylar process, angle of the mandible. Here you can see external auditory meatus, right? Yes. Here also you can see the maxillary sinus. Remember that sagittal slice is always useful for the assessing inferior alveolar nerve, and from right to left you can see the maxillary sinus also. See, it gives you the entire lateral cephalometric view. So reformatted lateral cephalometric view you can assess in your sagittal slices also. Here you can see the complete airway space. You can assess from here. This is your posterior nasal spine, or the posterior palatal area here. From here, you can assess this epiglottis area. This area is called as airway space. The entire airway volume can be analyzed with our CBCT software. So what you are going to acquire from that, if it is lesser volume means, obviously patient might be having the complaint of obstructive sleep apnea. So you can treat the patient accordingly based upon the airway volume. You do not know. This is the initial assessment. So sometimes patient will not be giving you enough data about this mouth breathing habit. Simply they want to treat. So even if you treat the orthodontic corrections also, if you are not treating OSA, the obviously patient will be relapsed in few years. So you should be correcting your origin problem first, OSA or airway space problem. Then the treatment will be 200% success. So generally, these are the data they are giving for the applications of CBCT in general dentistry. Endodontics plays a major role. Even surgery and other departments are playing a vital role. So CBCT in periodontology, how periodontists can effectively use the CBCT means we can assess the bone defect, whether the patient is having buccal bone defect or lingual bone defect or the periodontal bone loss, how much it affects the patient, the post-operative connective surgery. So we can assess everything with the CBCT, and we can create the model also. If patient is coming up with a severe bone loss, you can take CBCT, directly give the print, 3D printing with the CBCT. You can take the complete particular quadrant model. So you can show the model to the patient, see this is your teeth. So this amount of bone loss is there inside your bone, because we cannot see the or patients cannot see the bone loss, how much bone loss is there with the naked eye. So we can take the printout, the like how we are taking a A4 sheet printout, likewise we can take the STL printout of the particular bone area. So you can show it to the patient and tell them this much amount of bone loss is there in your third quadrant. So we need this much amount of artificial bone grafting. So then only it will be replaced. Post-operative also, after 6 months, once in 1 year, you can take the image and take the printout. You can show them patient for the education purpose. This is how we have treated. So this is one of the advanced modality to educate the patient about what is happening inside, how we are treating. So that is main thing. An application in orthodontics, generally we do this lateral cephalometric analysis manually, but nowadays so many softwares are there giving you accurate cephalometric analysis. Cephalometric tracing can happen with the 3D softwares. For that, CBCT is mandatory. If you take CBCT, you can do wonders in ortho. You can do aligners, you can do cephalometric tracing. Immediately we can do the printouts and start the treatment. So all those things can happen with the one image. For that, you need a full FOV for orthodontic treatment purposes. For the endo is almost 30% of CBCT usage nowadays is happening for the endo treatment purposes, because there's so many re-root canal treatment, sometimes failures is happening, and because of the calcification or extra canals, lingual canals, mesiobuccal canals, distal lingual canals, all those missing canals can lead to your RC treatment failure. Now we are in a demanding situation, like we should treat the patient with 100% success rate, because we are in a competitive world. Previous days we can do, okay, root canals happen, okay, it's failed, you can remove the teeth and put an implant or put the bridge. But nowadays patient is very much aware of that. Why I have done root canal, I need a minimum of 15 years guarantee. This failure is happening within 6 months. How done? So that means we cannot simply blame the patient. Sometimes doctors related iatrogenic failure is also happening. So in that case, you simply refer small FOV for the particular tooth. 3-6 RC, 3-6 small FOV. You can assess and see the small accessory canals. If you are really filling out that, then success will be 100% sure. So you can tell the patient, this is in 1 among 100 or 1 among 1000 people is having mesiolingual canals. This happened for you. This can be assessed with your CBCT only. So that is how we can explain the patient that's actually happening, right? So see this image. Can show you clearly the lingual canals. You can nicely see here this area. This can be assessed with your CBCT. See, one of the cases there shows almost 7 canals. We always equip 3 canals or else 4. 4 is also it's a very rare, but here it is happening for majority of the cases. If you really assess, you can easily find out this extra canals: mesiobuccal, mid-mesial, mesiolingual, distobuccal, mid-distal, and distolingual also is available. Next, we move on to the temporomandibular joint, which is one of the hidden field in our dentistry, because majority of the patient is coming up with the myofascial pain dysfunction syndrome or temporomandibular joint or internal dearrangement, some clicking noises. Every day in our OP, you can see one patient at least for this temporomandibular joint disorders. So you can assess with this CBCT and bone tumors or bone pathologies, alterations, everything can be assessed with the bone window here. See, this is third picture can show you this osteophytes. The reformatted images. Generally, this MPR window will not be helpful to assess this kind of TMJ issue. You should be orient the image or reformat the image along the long axis of the condyle, will give you the enough information regarding this condyle position or glenoid fossa or osteophyte formation. Everything can be assessed. Next, I told you this airway assessment. So, predisposition for the obstructive sleep apnea can be assessed completely with the volume of our oropharynx or airway. This is really helpful. So, this image can show you posterior, from the posterior nasal spine, you can assess till the epiglottis area, you can assess entire airway space. The glorious field here is implant dentistry for the CBCT thing. We have reduced, the studies shows the enormous results of the success rate of the implant with the help of CBCT. Pre-implant assessment and post-implant assessment will give you the complete information about the buccolingual width or mesiodistal width or the nearest anatomical landmarks, and how we can keep the future tooth position in that area. We can virtually place the implant and assess whether it hits a nearby anatomical landmark or not, and the bone defects and how much amount of the bone grafting needed, or whether the sinus lifting procedures are needed for the implants or not. So all these assessment can be done with the one scan that is called cone beam computer tomography, which gives the minimal projective distortion. So that is why all implantologists suggesting this CBCT for this field, because a 2D image always has a superimposition or distortion. OPG is also giving enough kind of magnification. So to avoid all those limitations, we can definitely recommend CBCT for this implant dentistry. See, as I told you, we can keep the future tooth position. This is called reverse engineering concept, right? So first we place the tooth. We can check the occlusion. Okay, this patient is having proper occlusion with the particular tooth position. So once we decide the tooth, based upon the tooth position, we can keep the implant. In that case, implant failure will be reduced. So if you place first implant means, you will be like based upon the implant position only, you can adapt this tooth crowns. It could be a zirconia crown or a metal crown, whatever the crown. So, but the occlusion will be changed. So to avoid that, once you place the tooth means occlusion, how we are doing teeth setting and all in our undergraduate system. So likewise, we can do the teeth setting in CBCT image itself. Once you finish the occlusion, okay, this occlusion is pakka, we can proceed with the implant. Based upon the long axis of the future tooth, we can place the long axis of the implant also. Or if you need that abutment angulation also, with the necessary requirement, you can adjust the abutment angulation like 15 degree, 20 degree. Likewise, you can adjust. So finally, the implant and tooth position both should be in accurate precision. The precision is very important here. So that is acquired with the help of CBCT. And one more thing, major thing is impaction assessment. So we might not know whether this is near to the canal or near to the anatomical landmarks or whatever. So we can assess all those impaction position, impacted canine position. So to help the orthodontist, to help the surgeons, this is really, really helpful to do the better extraction with the less complication to the patient. So you can prepare yourself. That is the main advantage of this thing. And one more thing is fracture. The fracture assessment is it's enormous helpful in the CBCT thing. So reconstruct a panoramic view, 3D construction view, all this view will give you the exact location, exact extension about this fracture. So here the parasympathetic fracture can be assessed. This is your coronary process fractures. Coronary process, even condylar process fractures. See here, displaced step defect, step deformity of the fracture can be assessed. Nasal fractures. See here, you can see the multiple step deformity of the nasal bone. Lateral wall of the nose fractures also can be assessed. Here, the multiple comminuted fractures of the nasal bone. This kind of root fractures also can be seen easily with a smaller FOV, like whether it's a horizontal fracture or oblique fracture, root fracture, at what level. So you can assess from the orientation, the path of the fracture from the buccal to the lingual. So all those directions also can be assessed. Based upon that, we can do the hemisection treatment or complete extraction. So we can decide that. So these are the general dental applications. So for each and every specialty, there are unique features of the helpful of the CBCT. So you can definitely refer based upon the irradiated area, which area, necessary area. The disadvantages are like you can see artifacts here also. If patient is having multiple metal restorations or any other fillings, obviously it gives you artifacts. See this kind of metal artifacts because of the already present FPD work or amalgam restorations, that also gives you a artifact. If patient is moving within that 14 seconds, if the patient moves a little bit, means obviously the motion or blurring double image artifacts happens. Sometimes the electricity error, kilo MA error, that also gives you static electricity effect. The ring artifact because of the manufactured effect. These are the samples of artifacts that can be corrected easily with the necessary requirements. So you should be knowing myth or fact before going into the entire CBCT field. So these are the collective points which we discussed so far. Like smaller focal spot means good resolution, right? That is the that is a fact. If it is a smaller focal spot, means resolution will be really good. Okay, and smaller voxel size also will give you a good resolution. High resolution means less radiation? No. If you are going for the high resolution, you have to give more radiation. So for the smaller FOV means, that is why we are suggesting smaller FOV. If you need a good resolution, you need to give high amount of radiation. So in that case, if you are looking for 1 or 2 teeth, means you can opt for smaller FOV because patient will be radiated with a smaller area. The radiation will be less in a small FOV, but you can get a good resolution. If you are going for the full FOV, high radiation, resolution will be good, but compared to smaller FOV, resolution will be less. Okay, so more radiation means more contrast. Yes, more radiation means more resolution, more contrast will be happen, but the disadvantage is radiation. Okay, smaller FOV, less contrast? No. Smaller FOV means good contrast. Okay, so long scan, more artifacts. Yes, if patient is doing for the longer scan, might move. Some artifacts will be happening if we are planning for the longer scan. Implant dentistry, you need to recommend for the larger FOV? No, you can opt for smaller FOV also. If you are going for the all on 4, all on 6, the complete entire prosthetic rehabilitation only, you could opt for large FOB. Or else if you're planning for 1/6 implant or 2/1 implant, means you can definitely opt for smaller FOB for the very less area, less cost also for the patient. And surgical guide, no CBCT needed? No. You need CBCT scan for the surgical guide. So you need to synchronize the CBCT bone data along with your intraoral scanning data. You can merge and bring out the complete hard tissue and soft tissue details. Based upon the details, you can fabricate the 3D printing surgical guides. So with that surgical guide, you can easily place the implants without any hassles. So CBCT, more price? Definitely not. You can start from the 500 rupees itself. So multiple treatment, not affordable? No. If you are suggesting for the multiple treatment for the patient, you might think, okay, patient might not be affordable for the scans, and it's not like that. You can definitely refer for the patient if you are doing for the multiple treatment. And these are the little bit facts and CBCT. Thank you so much for the wonderful option, Dr. Aditi. Here we have discussed so many things. And before prescribing CBCT, you should be assess the risk over the benefit. If you feel the benefit is on the higher side, means you can definitely opt for us. Or else if you are convinced about 2D technology or OPGs, it's enough, means you don't need to refer CBCT. If you think it's really needed, you can opt for that.
Thank you so much, ma'am. That was a wonderful presentation. And we could clearly see you're so crisp with your concepts. And I'll again say, like, you're a motivation for all of us. And, you know, being graduates, we never really got a chance to know CBCT in that depth. You know, it's maybe it was not that commonly used back then, but like today, I'm a lot more confident about CBCT post your presentation. So thank you so much, ma'am.
Thank you. If we get a chance, maybe in future I'll show you the tools and all, how to use the software.
Definitely.
We will see a lot of demonstration and hands-on about this software. I'll explain in future.
Definitely, ma'am. We'll be waiting for the day.
Yeah, thank you.
Ma'am, there were a couple questions.
Yes.
Ma'am, which generation are we using now?
Sidexis.
It is?
Dentsply Sirona.
Okay, no, like which generation is it? The number?
Pardon? I couldn't get you.
Like we said, the first generation CBCT used to take.
Fifth generation, yeah.
We're using the 5th generation. Okay, all right. And ma'am, how much does a normal scan costs?
Normal scan.
Right, a CBCT scan.
Yeah, starts from 500. Even in our Tamil Nadu, we are doing around 1,500 for the mid FOB. It goes up to 3,500 for the full FOB.
It depends upon the field of view.
Depends upon the field of view. In some of the center, they are having fixed rate like 3,000 rupees.
Okay. Okay. And ma'am, how much is the minimum field of view? Like, how can we minimize, how much we can minimize it to?
Yeah, it's around 5/5. That is the minimum starting FOB 5/5. You can standardly fix it in your mind. Okay, I can send the patient for the 5/5. You can clearly see from 1 to 3 teeth in 5/5 FOB.
That's amazing. Yeah. And it was, we were so spellbound to know the potential that the CBCT has, like right from endodontics, perio, ortho to fractures to sleep apnea and TMJ, like it has it all. And thank you so much for, making us aware and enlightening your words of wisdom to us. Thank you so much, ma'am.
Thank you.
Yes, ma'am, before we end, I want to give our viewers a gist of Dentist Channel, if you may allow.
Yes, yeah.
Yes, please. Ma'am, you can end your screen share.
Hello?
Hello, ma'am, I said you can end your you may end your screen share.
Hello?
Am I audible?
Can you hear me? Hello?
Yes, ma'am, I can hear you. Yes. I hope I'm audible.
Yeah. Your voice is breaking. So sorry.
Okay, it's all right, ma'am. I'll share my presentation now.
Yes. Yeah. Please.
Yeah. So, Dentist Channel Online, healthy smiles, wealthy lives. We are the first digital dental media in the country, and we offer multiple services to dental professionals, dental students, dental organizations, and dental business persons as well. You can read news articles. You're most welcome to attend our webinars. We offer multiple courses and cater with multiple events as well. You can submit your articles, your videos to us, and we'll publish it on the website. And there are multiple services that we offer, like you can watch our premium videos, you can be in our partnership for dental businesses. And I take huge pride in sharing that we have conducted over 700 plus live dental webinars with 40,000 beyond participation certificates that have been issued. There have been multiple dental workshops, and we were honored to host over 400 plus national and international speakers. And we have 300 plus oral healthcare videos under Save the Tooth campaign. This was another milestone that we achieved. We got the certificate of maximum speaker participation in any virtual dental program on oral implantology, and we made our way to India Book of World Records for that. This is a sample of the certificate that we offer, and each certificate contains one CPD point. We would love to connect with you and would love to host you for the upcoming webinars with Dr. Muthulakshmi Ji and Dr. Arul Prakash. And you can connect with us on Facebook, Twitter, Instagram, LinkedIn, YouTube, WhatsApp, and Telegram. We would be more than happy to collab with you and to solve your queries. Thank you so much. And ma'am, we had a very valuable time with you. Thank you so much.
Thank you.
Thank you. We wish you very best for your future endeavors. And we are all somehow somewhere rooting for you.
Yes. Thank you.
Thank you so much. Thank you, ma'am.
All the best for your futures.
Thank you so much, ma'am. Thank you. Means a lot.